Christiana, Shohunle, Dolapo, and I'm here with.
My name is Dr. Iseko. I work with Cardio Care Hospital. I'm an interventional cardiologist with Cardio Care. I'm happy to be here. Excited really to be here.
Okay, so our topic for today is evaluation and management of palpitations. It's a very interesting one. So please pay rapt attention. If you have a notebook, a pen, please just stay with us, and we're hoping that you will learn a lot from this webinar today. You're welcome.
All right, so if you look, you have a chat box. You can I think everybody has access there. You can make your comments, and then there's a Q&A box as well, where you can enter your questions and all of that, so that we can now follow up with you. If you have any questions during the course of the presentation, just write in the Q&A box, and it will be answered shortly during the presentation. We trust that you'll have a great time as we go ahead. This is from Cardio Care Hospital here in Abuja. Cardio Care is a multi-specialty hospital focused around cardiovascular medicine, interventional cardiology, cardiac surgery, and internal medicine. And we are just talking about palpitations. Our hope is to make cardiovascular care common, make great cardiovascular care common, so that nobody has to travel abroad for advanced care. But of course, one of the basic things to start with this, and I want everybody to get and understand these very simple guidelines. We take about 40 minutes to go through this, and I trust that you will have a great time if you have any questions. So Cardio Care is part of the Living Hospital Group, which was founded in 1982. We have the Children's Hospital, which is focused on pediatrics. And of course, you can always join the Children's Hospital webinars, which happen also every month for pediatrics. And then we have Living Hospital, the Mother Hospital, which is in central area Abuja. So glad of you to join us. This is what Cardio Care looks like here in Abuja, and it's growing over time. So, objectives, Abi?
Yes,
why are we here? So, Dr. Shohunle, why are we here?
So we're here to understand the definition of palpitation. What are palpitations? What are the possible causes of palpitations? And when we see patients in our clinic, how do we assess them? And eventually, how do we manage these palpitations? So that is what we're here today.
All right, so we'll go straight into it. But one other thing I've added is to give a snippet, something that can help us all in relation to cardiac devices. You know that cardiac devices are relatively new in the management of arrhythmias in Nigeria. And so there are many people that don't quite know what cardiac devices do. So if you wait on to the end, I will take some time to talk about how cardiac devices help patients with heart conditions, prevent arrhythmias, treat arrhythmias, and so on and so forth. So I will share some of that as well as we go down. So by way of introduction, it's a common and non-specific symptom. I'm sure Dr. Dolapo, you've seen it a lot of times, you know. Sometimes it's benign, but more often than not, it is not. It is something that could be life-threatening. Could be a symptom of something that's more life-threatening, but most commonly benign. But when you miss it seriously. It can be intermittent, it can be regular, it can be sustained, or otherwise. So, how do we define palpitation?
Okay, so sometimes when a patient comes to the clinic serious, they can have different descriptions of it. Some will describe it as feeling a beat in their chest. Some will say that they feel it fast and then there's a thump. And some will say that they just have a feeling of their hearts moving fast, even when they are at rest or at night when they want to sleep. So it's not a very specific way of describing palpitations for everyone. So it differs from patient to patient, basically.
Exactly. So, but generally, when people talk about this, they say an uncomfortable awareness of one's own heartbeat, typically undue. So whenever somebody is able to feel their own heartbeat, and undue awareness of their heart action, more often than not, is what we define as palpitation. Now, whether it is physiologic, or non-physiologic. Like if you run up a staircase, so if you saw a lion, that may likely be physiologic. Okay, so physiologic or non-physiologic. So whether it's physiologic or not, it's a different matter altogether. However, anytime people are able to feel their heartbeat, rapid, irregular, feeling it in different manners, then we are talking about palpitations. So essentially, it contributes about 16% of OPD visits, and a lot of ER visits, 25% admission rate, based on this work by Weber et al. Third most common complaints for palpitations in cardio care, maybe hypertension, maybe heart failure, chest pain. Then maybe in cardio care, it should be around fourth or fifth common reason why people come to cardio care hospital. And of course, almost half of them are cardiac in nature. So based on people with their different complaints, yeah, it could be cardiac. So why do you think we have palpitations?
Okay, so palpitation are due to alteration in the heart rate. For example, in patients with sinus tachycardia or bradycardia.
It's just faster or slower.
Yes, exactly. And then when there's alteration in the heart rhythm, like in an AFib, or when there's augmentation of myocardial contraction in anxiety state or some drugs, some microgenic drugs, and then alteration in subjective assessment like in anxiety state.
Yeah, so a lot of times this may be the common reasons why. We know that at least 43% are cardiac, but if you see that most of the others are non-cardiac, from psychiatric, which is anxiety or anxiety related, to idiopathic, to miscellaneous. But for these 42% that are cardiac, and for a similar percentage of those that could become life-threatening, it's quite important that everybody that sees a patient complaining of palpitation is able to adequately decipher what is important and what is not important. At the end of this, I will show you a very simple algorithm, which we also share on our WhatsApp group for those that are in the Abuja Medical Symposium WhatsApp group, so that you can easily use it to evaluate your patients. But whereby I did some work around palpitations, and it shows this. And for the cardiac causes, rhythm disorders are the main disorder, and then sometimes people have a structural heart disease, dilated hearts, and then they could not have. So what about predictors of cardiac etiology? If you see a patient with palpitations now, how can you be able to sometimes predict whether this is cardiac or not?
Okay, so the independent predictors of cardiac etiology are the male sex, and then the description of irregular heartbeat, like I spoke about earlier. And then if they have a past history of heart disease, like some people that have hypertensive heart disease, ischemic heart disease,
left ventricular hypertrophy, amyloidosis, or the like.
Yes. And then if the event is greater than 5 minutes.
Okay, so when somebody has only one of these, the chances of it being of cardiac etiology is 26%. When somebody has two of these, so 14% and 71% for three. There are other things, however, besides these are independent. And some of the other things are associated symptoms that could be like fainting, like sweating, like all those vomiting and the like. So cardiac causes may be rhythm disorders or non-arrhythmic cardiac causes, meaning there's not an arrhythmia, but it's the feeling of palpitation is coming from the heart. That's hypertension, mitral valve collapse. Mitral valve collapse, you're actually feeling the thump of the valve collapse, outlet obstruction, RV dysfunction. But the rhythm disorders, premature contractions like ectopics in the atrium or the ventricle are perhaps one of the very most common, and then atrial disorders. Of course, those with bradyarrhythmias, when the heart rate is too slow, people can also have palpitation. So it could be too fast or it could be too slow. Either way, palpitation is not one to write off as somebody is in their mind, except you have talked about it. Okay, can you talk about some of the psychiatric things related to that?
Okay, so patients with panic attacks can have palpitations.
Yeah.
Some that have anxiety, some are depressed, And then some who have stigmatization can also come with palpitation. But it's important not to ignore the cardiac causes.
Yeah.
So we not just say, okay, this patient is anxious, because sometimes they can even come in a mix. It can be
Exactly.
psychiatric state, and then you also have cardiac causes. So you don't just ignore and say, okay, it's because of your anxiety. You have to evaluate.
Very, very important to state that there is nothing that stops somebody with a panic attack from also having an MI, or somebody from having an MI from having a panic attack. People could have a long history of psychiatric illness, and sometimes people with psychiatric illness may not get adequate care because people might eventually just think that it is from their mind that they are complaining about, and this is not real. So it's very important that everyone that presents with palpitations is properly evaluated. They cannot be chopped off as psychiatric. So while psychiatric causes contribute 1 in 3 of the causes of palpitations, they must be evaluated thoroughly as if that was not the case before you come to it. So more often than not, you end up as a diagnosis of exclusion. Okay, so there are some miscellaneous causes. What can you talk about this a bit?
Okay, so the other miscellaneous causes include hyperkinetic circulatory states like anemia.
Yeah.
When the circulation is low, it has these factors to compensate, and then fever, thyrotoxicosis, hypoglycemia. We have some drugs like drugs used in asthma, aminophylline, atropine, which causes this. Also, drinks like caffeine, which are common. In your history, you have to ask about these.
Energy drinks.
Energy drinks, cola nuts, bitter
cola. What that energy drink? Fearless. Fearless.
Yes, and then cocaine, amphetamines.
So definitely you have to review all of this. Now, the other things that you can put in, skeletal contractions, mastocytosis. We will not spend all of. So how do we evaluate? There are 4 rules in evaluating palpitations. Okay. For me, the first and most important thing is ask yourself, is this life-threatening? Remember, all palpitations are not arrhythmias, and many arrhythmias do not palpitate. So the fact that somebody says in the history I don't have palpitations does not mean they could not have a life-threatening arrhythmia. Very, very important. So the first thing evaluation is this life-threatening? Okay, so we've talked about some independent predictors, and we'll talk about others. The second thing is having decided that are there possible risks from this arrhythmia, or what the palpitation is portending. So the palpitation is not important, but not life-threatening. For example, the patient has atrial fibrillation. What's the risk of stroke in that person? What's the risk of sudden death? What's the risk of worsening heart failure? Okay, then number 3, do you need to hospitalize? And number 4 is specialist consultation required, and how urgent. So if it's urgent, of course, you can get across to us, but especially you need to answer these 4 questions in your mind anytime somebody comes with palpitations. And being that it's a fairly regular presentation of patients, these 4 questions will be rapidly answered in your mind. Is it life-threatening? Are there possible risk of direct effects? Do I need to admit this patient? Is specialist needed, and how quick the specialist needed? Of course, there are some arrhythmias, palpitations like that you have to treat. Specialist may be needed, all right, but you have to treat because they may cause a cardiac arrest, and that is in the realm of ACLS. We are not discussing today, so calm down a bit before we go ahead. All right, so can I talk about the approach, Dr. Shohunle?
Okay, so the approach will begin with a focus history.
Yeah.
We have to start, I talked about the history of all those substances like taking alcohol, taking tobacco, and the rest. And then you also have to ask for a history of any cardiac disease previously. And then from the history, we'll now go on to investigation. We'll do ECG, very important, echo. And then ECG is important because on the ECG, you can now diagnose or find out if there are arrhythmias and then treat appropriately. And then the diagnostic evaluation as well. Okay, so I'll just go in depth a little bit into what she has said. So she's talked about the history and trying to rule out underlying cardiac abnormalities, which is very, very important, especially if there's already a pre-existing history, and then the history of drugs or other things that will cause it. Now remember, we want to do those 4 things. Is it life-threatening and the like? So what's the character of it like? How fast did it start? How did it stop?
what preceded it, what were the associated symptoms, any relief, any family history, and then what is missing from this slide is personal history, drug use, and then personal history of heart disease. So very important to take in the history. So let me focus on that. So age of onset, when did it start? Very important. How did it start? So is it true that palpitation, is it true palpitation or something simulating? So sometimes some people are saying they have palpitation, but they don't really know what palpitation means. So you need to ask them, what do you mean by palpitation? You might find out it's actually chest pain. My father is chest discomfort. Now we have a different webinar on chest pain. I think we have some of them on our YouTube channel. You can go there and review them. So if it's chest pain, what is it? If what you mean, what is it? So is it true palpitation? Then is it physiologic after running, after sexual activity, after emotional upheaval? They fought with their husband or their spouse, and now they're having palpitation. They now run to the hospital doctor. You know, so is it more when alone and quiet with thoughts? So this kind of thing tells you that it's unlikely to be very, to be cardiac, especially when somebody says they are fine all through the day. It's when they are alone with themselves on their bed at night and awake. It never wakes them up at night. It does not interrupt their activities. It's only when they are thinking about life that they start feeling palpitations. It's less likely to be it. And then, very important, is there a associated symptom of lightheadedness, fainting, diaphoresis? If you have any associated symptom with palpitations, it's more than likely that that palpitation is unlikely to be completely benign. It could still be psychiatric or the other, but it's unlikely to be benign. Patient feels like fainting, they feel like falling, they have lightheadedness, they feel like finding a seat. They were preaching and they felt palpitations and they had to go and sit down. Okay, or they were in a rally and they are sweating a little bit. They have to pour water on them, get them coke, and after a while, went and no, that palpitation is unlikely to be benign. So when you have this kind of history, it's important to look at it. Now, other history is it coming on and off, or is it always there? Okay, so if it's always there, it means that you, at the time you are sick, you're able to feel it. If the person is telling it's always there, nothing is sometimes it's not quite true. So now we'll now look at it. Abrupt onset comes on and stops. Could it be an SVT, a supraventricular tachycardia, meaning it's arising above the ventricles, a ventricular tachycardia, or a sick-signal syndrome, or gradual and gradual termination? So they started thinking they had a fight with their nanny, and before they knew it, they started feeling their heart, and then they went and sat down and had to calm down. While they're watching the movie, it came down. Those ones are most likely to be benign. So if it happens suddenly and stops suddenly, it likely to be cardiac and the consumption. And if it happens gradually and disappears gradually, it's unlikely to be. Okay, so now if they do any vagal maneuver, okay, like Valsalva, they do all those kind of things, does it get better? They try and blow, they try and bear down, and then if it worsens at night, these are some important history to look at. Some patients are very smart in the way that they're able to keep records. So they can tell you that it's regular, it's irregular, it feels like a drum beating, and some people tell you that they come, they will tell you exactly how it is. Now with that, you'll be able to pick whether it is what kind of palpitation you are dealing with. So it's very important to ask about it, and there are a lot of things that you can look at in this regard. So sudden onset, very fast and regular, fast and irregular, it comes very fast and it's irregular, and sometimes it goes off and on. So very important. Now, if somebody already has pre-existing heart failure, when we have palpitation, we do not take it lightly at all, because it could portend very poor prognosis, and of course, radiation. A lot of the AV nodal tachycardia will get into the neck, and if somebody has a complete heart block, they could cause some AV dissociation. So they could feel it in their neck as well. So very important to look at it. Now, dyspnea, chest pain, collapsing. So they collapse after they had the palpitation, they collapsed, or they had dyspnea. All of these ones typically are something that we must bring in and evaluate, and besides all the others. Now, for the physiological ones, we need to do that diarrhea, excessive sweating, heat intolerance, weight loss, heavy menstrual bleeding, things like that, things that could portend blood loss. All of that are very important. All right, so this is what you're talking about. Can you Can you talk about it?
Okay, so like we said earlier, the past history is very, very important.
Yeah.
And you have to ask whether they've had any ischemic heart disease or any history of that, valvular disorders, heart failure. Also want to know, are they asthmatic? Because they could be taking some drugs like amlopilin, salbutamol, which can cause palpitation. Also want to know, okay, are they taking any drugs that, like I mentioned earlier, or are they taking any substances like energy drinks? Is there any family history of sudden? Is there any family history of sudden cardiac death? It's very, very important because if there's a family history of that, it can mean that they have predisposition to some inherited um, cardiac diseases and which can be now presenting as palpitations from presentation.
Yeah, very important. Now, when we examination will not find anything. A lot of times, examination does not find anything. But if you are lucky that they are having palpitation at the same time, you may also get some of these things that will point to something. They have fever, they have slow pulse, a fast pulse. Like it happen on and off, but it's very important to look at this and then to help the diagnosis. They have anemia, they have thyroid signs. Please, if you're examining somebody with palpitations, you must examine that neck. You must check and document if there's any sign of an enlarged thyroid gland, of proptosis, eye bulging, raised GVP. There must be a full cardiac examination. So now, investigation. Can I talk of examination?
Okay, so the investigations that must be done, the first one will include the ECG. Typically in cardiac care, any patient that comes in an emergency, we have 10 minutes time. In 10 minutes, the ECG should be ready and interpreted. And then we also have the ambulatory Holter ECG because sometimes that ECG that we do on presentation may not really give us a clear picture of any arrhythmias. So that's why sometimes we ask for, or in palpitations, we actually ask for Holter ECG, which can be done in 24 to 96 hours. It's a machine that's 1/24 to 96 hours, and then it can show us a true picture, and then any arrhythmia that is not caught at that time can be seen when it's interpreted. Then we also screen using thyroid function test. We also do electrolyte screening, a full blood count, and then we also do cardiovascular risk profiling by sending for the BP profile, the HbA1c, and uric acid as well.
So the Holter ECG is very important. It's a small device. We attach to the patient's body, not much bigger than your phone. The patient goes home with it and comes back after a certain period, 24 hours, 48 hours, 72 hours. During that period, the patient will keep a diary and let us know when they felt so that we can check and see corresponding any symptoms they felt. But also we can also examine for disruption they never feel. And sometimes during that Holter, we find really life-threatening arrhythmias that are happening. So even the ones that the patient did not complain about, sometimes we find them during the Holter. But like I said, a lot of patients have almost a normal one, but you cannot allow them to go in that just like that. So other things, we talk about thyroid function test. Echo is very, very important. Very, very important to exclude structural heart disease. And sometimes if we think it's mediated by exercise, we need to do an exercise stress test. So if you have a patient, you've gone through the first line and you're still having problems, you may need to refer for us to do the Holter, to do the echo, or to any of your local cardiologist for the same. All right, so there are some things we can see on ECG that may be reading markers of an arrhythmia. So if you find a delta wave, if you refer to our webinar on ECG interpretation or on our YouTube channel, you'll be able to see this and understand that. If you see some of these things, either a delta wave, atrial enlargement, left ventricular hypertrophy, Q waves, short QT, T wave inversion, all of these could tell us that there's a structural disease or something is happening there. So you cannot say this is anxiety when you have an abnormal ECG that has any of these findings. And so if you look at these other things that we could do. Now, one thing that we don't do often is called a loop recorder. The loop recorder is a very small device, about the size of half my finger. We insert it under the skin, very simple in the clinic, and the person goes away with it. Now, the loop recorder can be there for 1 week, can be there for 1 year, okay? And it's just keeping a full implant, that's the loop recorder. Can be there for up to 2 years. The problem, however, is very costly. Okay, so it's very costly. So apart from that, people can have, we have those that have a arrhythmia once in 2 months, once in 2 weeks, it looks very severe, and they are killed. So this was the Holter we talked about. Can you talk us through the Holter?
Okay, so the Holter is very important, like you said. It's a device that is just the size of your phone. It is mobile, you can carry it around. You can even put it on you, you go home, you come back. It's like an ECG, like we said, and so there are leads attached to your chest. The patients can continue with their daily activities.
Yeah.
And when they come back, we'll have the results interpreted and evaluated.
This is the loop recorder I was talking about. We have external and implantable. This external one can last for weeks. And the thing about the external one is whenever the patient feels an arrhythmia, they will press the button. So it is there recording, but it's not recording every single bit. So anytime they feel the arrhythmia, they press the button. Then it will store for the previous 1 hour and for 1 hour after, something like that. 30 minutes after, 30 minutes after, and store that one and like that. While this small one, this reveal here, this is the one that we easily implant sometimes. And you can see there are different ones. Reveal eye link. This is what we commonly have in cardio care. It's quite small, can last up to 2 years. Yes, small device. We set it under the skin. So let's go to this algorithm. Let's go to this algorithm together. Very, very simple. And with this, you will understand how to manage palpitations. So we'll go now. Let me just get a very good. Okay, good. So assuming a patient comes with palpitation, patient presenting with palpitations. All right. Number one, take history, like we talked about, all the history of onset, character, underlying disease, family history, cardiovascular disease. That's the first thing. Get a 12-lead ECG for all patients. It is an abomination not to do an ECG. I mean, it's akin to quackery. Patient has palpitations, you must get an ECG. And we talked about certain things that we see on the ECG that can give us, we said Q waves, left ventricular hypertrophy, delta wave, you know, PVCs, QT interval, atrial enlargements, complete heart blocks, all of that will easily just be there on the ECG for you to be sure. Now you go next to some first level investigations, full blood count, anemia, sign of infection, chemistry, calcium, phosphate, TSH and thyroid screening. And then in some patients, we do cardiovascular risk profiling. Look at their cholesterol, look at their uric acid, their HbA1c sugar profile, and then in a few people, we have to do drug screening. They were appropriate. Now, having done all of that, if the answer is not still there, you need to go to the next one, which is echo plus or minus Holter ECG. If you have an abnormal ECG or even a normal ECG, you want to do a Holter, so I can give you a 24-hour view, and you want to do echo. So our standard here is to have echo for virtually all the patients. And it's very simple. Who has a structural heart disease? They could have a normal blood pressure, but they have a structural heart disease that is making them come up with it. So now after the echo, we'll now decide. After this first step 1, 2, and 3, a lot of times we end up here at 4A. No cardiac problems, normal Holter, normal echo, TSH, chemistry, everything is fine. Then we now treat anxiety, drug disorders. A lot of patients will find that they started a new drug, a new supplement, quote unquote, and sometimes it could be a drink or the other. So we adjust that. So you reassure. If there are structural or functional disease that is present, don't just reassure. Refer to a cardiologist if they're not getting response. Okay. Now we now come to 4B. In those that we did not find, we now suspect a structural heart disease, either from the echo, Holter, or from cardiovascular risk profile. At this point, get a cardiologist review, or you can refer to cardio care hospital. So that's what we'll do. The next thing now we consider is Holter or event monitoring. Event monitoring is this device that I showed you here. It's an event monitor where the person presses the device when he can feel when he feels something. So that could be very helpful. So event monitoring for 2 weeks if palpitation is less than daily. However, if palpitation is daily, then you want to just do your Holter. So after the Holter, now what now do? You now come to step 6. After the Holter, you either do Holter or you do event monitoring, depending on how frequent the palpitations. You will now have 4 things. 6A, there were palpitations, but when we look at the Holter, everything was fine. Even the PVCs we saw were less than 0.5%, and every heart is entitled to 1 or 2 PVCs. so not serious. So, and then when we check the time they say they're feeling palpitation, when we check their heart, it was normal. Those ones, we take them together with the extracardiac causes to treat anxiety, exactly, reassure. But we can still continue to follow them up, and if they're not getting better, please consider a review by a second party or by a cardiologist, because there could be something you missed. All right. Now we now have these other people. First set of people are those that have plenty PVCs, premature ventricular contractions. In those, we now typically use this Lowndes grading system. Those with a low Lowndes grade and infrequent grade 1 to 2 typically reassure. If there's a structural heart disease, we may give some low dose beta blockers or drugs, but often than not, we typically treat conservatively for Lowndes grade 1 to 2. While those with Lowndes grade 3 to 5 on their Holter monitoring, we typically will introduce medications, and depending on whether they have a structural disease or not, they may be considered for a device therapy. Now, for C and D, some with severe arrhythmias, either ventricular or non-ventricular. So if they are ventricular 6D and it's quite important, we'll now decide on the next line of care. So we treat the arrhythmia as appropriate. At this level, from 6B Lowndes grade 3 to 5, and 6C and 6D that you're seeing on your chart, this should not be managed at a non-cardiologist level. This should be managed at specialist level. Okay? So very important, because if you don't manage it appropriately, what you will see is that you will not see the patient again. And that's not a good thing. Not that the patient got better. Sudden deaths, a lot of times. Okay? So you should really, so you come to this level, 6C or D, you have a non-ventricular, it could be intermittent atrial fibrillation. It could be something else we need to treat. Or it could be an intermittent complete heart block, and we need to treat. And then some will now have a ventricular arrhythmia, full-blown ventricular arrhythmia, maybe ventricular tachycardia, on and off. Some people really devastating, almost fatal arrhythmias. You cannot allow them. So in some of them, treatment with drugs is enough. But in a lot of them, they will need, in addition to drugs, device therapy. So that's the device therapy I'll talk about a little bit after this. Okay, so Dr. Shohunle, so the patient has now come. 32-year-old woman, she was just divorced by her husband 2 months into their wedding, and he slapped her 15 times. Abi? Good. And now she's having palpitations and she cannot sleep. So what will we do?
Okay, so first of all, when she comes, we take a full history.
Exactly.
Taking into consideration the character of the palpitation, the duration.
Correct.
We also want to evaluate her appropriately after examining her. We want to evaluate her. We must do an ECG. We must do a Holter ECG.
Echo.
We must do an echo.
Yeah.
To exclude all the extracardiac and cardiac.
Now, I tried to deceive her by giving her a sober story. Hopefully, she will respond. I said, no, it's normal. Nothing stops that person from having a cardiac problem. Just because they had a cardiac problem. In fact, that may have been why they divorced. Who knows? But you just say, this was wrong with you. Just take some sleeping pill and sleep. And they sleep and don't wake up. No. So, yes, you must still go through the algorithm. So, we now said echo, structural disease, review all of that. What happened to me? Review all of that, and then we are fine. Okay. So, sorry about the screen. Screen will come up shortly. All right. So review all of that, and then we go. So what else? What else would you do? So what else would you do now?
Okay. So apart from that, we would complete the evaluation by reviewing all the tests.
So if you find that there was no structural heart disease, echo was fine, ECG was okay, and Holter did not show anything significant, what will we do next?
And then we assure her and then keep monitoring.
Correct. And if there's still a lot of concern and there are some issues, you may need to refer as appropriate, okay, in case there's something that could have been missed. Okay, however, if there's a strong, if you do not see structural you're suspecting, you might do a Holter or event monitor, and depending on how severe it is, you get a cardiologist involved and give appropriate medication for the arrhythmia. However, some patients, in addition to drugs, need device therapy. Why is it important to talk about device therapy? There are a lot of studies that have shown. So some people still believe that if you just give drugs, no. If you don't have money, you don't have any hope. Yes, drugs is better than nothing. But a lot of the studies have shown that drug therapy alone for these life-threatening arrhythmias is not enough. It's not enough. And patients that have had the devices live significantly longer from those that do not have the device, especially those with at high risk of arrhythmias. So sometimes when somebody is presenting with palpitations, you did not find tumor. The patient has heart failure. The ejection fraction is low. You did a Holter, it was normal. That person is at high risk of a fatal cardiac arrhythmia. That palpitation drew your attention, all right. You must put a device for that person. So at this point in time, I will now go a little bit more. So who will you refer? Yes, who will you refer?
Patients with frequent or persistent arrhythmias.
Yeah.
Patients with symptoms like syncope, breathlessness, persistent chest pain, or family history of sudden death or recurrent syncope, and then significant ECG findings like we've spoken about, and then any echo structural abnormalities we see. Okay,
fine. So if you find any of these problems, you typically should consider referral. This is not the one that you say, and of course, the final reason to refer is, I don't know what's happening. I don't know what's wrong. If your answer is, I'm not sure what's wrong. So there are so many things we can do to treat, but once they are an arrhythmia confirmed or significant this concern, you have to talk. So I'll take a few minutes to just talk about cardiac devices. Of course, you know, I'm intervention, so how will I not talk about cardiac devices? So thank you for joining us. This is Cardio Care, Nigeria's Center of Excellence for Cardiovascular Medicine. All right. So typically use a cardiac device to keep the heart beating with a normal rhythm. Somebody may have presented with palpitations, which actually turned out to be an arrhythmia. Remember, we said not all palpitations are arrhythmias and not all arrhythmias palpitate. So whatever reason got them into your clinic and you're able to evaluate, and you find out that they may need pacemakers, ICDs, or CRTs, this is what it's about. Essentially, the process is simple. We go and find a vein just under the clavicle, typically the axillary vein, extrathoracic, and then we insert a small lead to create a small pocket. Typically, we do it awake, maybe just subconscious sedation, and then through that axillary, typically, or extrathoracic subclavian, we take our lead into the heart. We may put 1, 2, or 3 leads. Yesterday's case, I did our 3 leads. Okay, depending on the type of device that is involved. And this is the same way we do for ICDs or for pacemakers. Okay, so essentially that's what it is. So if you have patients you have done, and then the ECG is showing you sinus nodal dysfunction, AV block, or the like, we typically will go on to review with all of these algorithms and decide whether this patient will qualify for device or not. Okay, and there are lots of things involved. I will not bore you with this because of time, but just to know that a lot of time people with active bradycardia, you check for reversible symptoms, you might check for toxicity from drugs, and if you have taken care of all of that and there are still problems, then you might consider treatment. You can use beta agonists if you think it's just acute and that will go away with time. And sometimes, yes, aminophylline is used in a short-term regard. This is why, to raise up the heart rate. So this is why people that are using aminophylline, franol, and the like typically will have a lot of symptoms. And then if there are still continuing symptoms, you might consider. Anybody with hemodynamic instability and they are critically ill due to bradycardia, they definitely will likely need some form of pacing. Typically, we'll give some pacing initially, and then you might proceed to permanent pacing. So look at this patient, a 52-year-old male, heart failure, reduced ejection fraction. Ejection fraction was 25%. This was his echo, looking like this, not very good. And then this was his ECG. Now, if you look at this ECG, imagine the patient came to you with palpitations. Yes, what can you see?
I see some broad complex QRS, some broad QRS complexes, multiple.
Multiple. Great. So these are the normal QRS and these are the broad complex. These are PVCs, premature ventricular contractions. So when premature ventricular contractions happen in 3 or more, we call it a ventricular tachycardia. Okay, and when that ventricular tachycardia happens for up to 30 seconds, we call that sustained. If it is less than 30 seconds, we call that non-sustained. So what we are seeing here is a non-sustained ventricular tachycardia, which could portend very life-threatening arrhythmia, together with this patient that ejection fraction is low. Virtually all patients with low ejection fraction need a cardiac device or the other. So if they came to you with palpitations, they are given a further warning that you should do the right thing and get them the appropriate device. So at a point in time while on admission, he developed a cardiac arrest. Remember that PVC that was coming, it now continued and he lost and became sustained exactly. And he lost consciousness. At this point in time, he started to ventricular fibrillation. And then we had to shock and he came back. So what do we do next? We put an ICD. After the ICD, we could give him all the drugs. So so who do we give ICDs to? ICD means implantable cardioverter defibrillator. Implantable cardioverter defibrillator. Essentially, that device that we use to shock patients when they're having a cardiac arrest, we implant it into the heart. It now is constantly monitoring the heart for any life-threatening arrhythmia and it treats it. Just like in Ericsson, the Man U player. I don't know where he is. I don't think he's Man U again. He's not a Man U again, I mean. I don't know where he is. But it does like in Ericsson. And in that Cameroonian, who unfortunately died, he had a cardiac arrest. I've forgotten his name. He had a cardiac arrest in the Premier League. Not full. There's another one that had a cardiac arrest in the Premier League. No. There's one that had a cardiac arrest in the Premier League. They put he had to stop playing. They resuscitated him. They put an ICD for him. He could not come back to play. After like 5 years, he now said he's tired. They should remove it. Within 1 year, he died. I've forgotten, but he was in the UK. Okay, so those people that are cardiac arrest survivors or we think are at high risk of developing a cardiac arrest, or they have structural heart disease, and when you were evaluating for the palpitations, you saw times when they had VT sustained, you need to put in an ICD so that when it picks it, it can treat and the person doesn't have to die. Very, very important. Anybody with heart failure or ejection fraction less than 35%, very, very important. Okay, so look at this patient. So what can we see? What did we see now, Dr. Shohunle? This is an ECG for a patient from a referring hospital. Yes, I know P waves. And we can see a broad, complex, rapid, just like that one. So this person is having more or less a sustained ventricular tachycardia, especially when it lasts more than 30 seconds, right? Yes. So but when she came here, it was fine. The ECG was looking okay. But once somebody has had this and they survived this, you should significantly begin to consider an ICD placement. So eventually she started having shocks, having ventricular tachycardia, which requires shocks. Of course, we have to put in an ICD for her. And this is an ICD in situ. You can see this is a normal reading. Okay, I want you to look again, and you see an abnormal reading, and then the ICD shocks her, and it changes to a normal reading. So that's how the ICD works. So sometimes you can have this ventricular tachycardia sustained happening, and this is when we typically will call it an electrical storm. Okay, so very important. All right, talk about this patient, 57-year-old heart failure, why QRS, not doing well, repeated. This is the kind of patient that I talked about, I did yesterday. We put in what we call a resynchronization therapy device. It's one of our biggest devices, typically for patients with heart failure, where we have to put in 3 leads, one into the LV coronary sinus, one of the veins around the heart, and another in the right atrium, and another in the left atrium. It can act as a defibrillator, but it also helps to pace the heart in an organized manner. So this is what we call cardiac resonation therapy. Very important. To just talk about devices. Now, the thing about an ICD, ICD is like a pacemaker with extra features. It can pace, if the patient needs a pacemaker. It can give a shock. It can pace higher than the abnormality, what we call anticardiac pacing. And of course, there's a lot of reference for it in that regard. Okay, so when we will now use CRT, typically we use CRT once the QRS is prolonged. The patient has low ejection fraction, is having all of that, we typically will import CRT. Very, very important news. So we have more or less come to the end of this webinar. But I want to make a very quick announcement. We now have cardiac surgery available all day, every day in cardiac care. Okay, thumbs up in the chat box or a reaction, a thumbs up. We now have cardiac surgery all day, every day. The days of somebody has a cardiac hole in the heart or anything, let's fly to India. Where do we go? What can we do? In the whole of northern Nigeria, now there is everyday cardiac surgery now available in cardiac care, and we are very, very happy for that. Trust God that first we're about to do quite a number of cases, just like we've done for interventional cardiology. These cardiac devices are all day, every day. Heart attacks, we are doing stents every day, devices every day. We have senior residents. We have people coming here for training and posting. They are all welcome. And now cardiac surgery will now be every day for everyone at every time. If you know somebody that can donate to help the very poor, we are doing some charity, yes, but we also need help to make sure that we can reach the ends of Nigeria. So very, very important announcement for us. I'm very happy to announce that. So if you have your patients, VSD, ASD, dissection, valve, CABG means coronary artery bypass graft. That is the needs for the coronary arteries or any of these things. Refer them here at the Center of Excellence for Cardiac Services is now available for us, and we are grateful to join. Great. So you can partner with us. You can send any of these to us, and then we'll gladly take part of it. So if there are any questions, I'll take them. I'm looking at the chat box now. If there are any questions, we will now take them. All right. Somebody says, so can you?
Okay. So the first question is, please, how do we differentiate significant from insignificant irregular heart rhythm on ECG?
How do we differentiate insignificant? What do you mean is insignificant? Anytime the reading on the ECG is abnormal, it is significant. All reading abnormalities are significant. Just take it as a rule of thumb. And whenever you see reading abnormalities, 99% of the time they are significant. And it's better that you have a specialist side for you that is insignificant than for you. So if you refer to our teaching on ECG, you will probably get more information in detail about reading the ECG, understanding the ECG, and knowing significance from all significant. Okay.
So Lua says, if we are to buy a device for my clinic, which do we get? A cardiac monitor or an ECG? Please, what is the difference?
This is like asking whether to buy rice or stew. You need to buy both. So the cardiac monitor is one that you are using to have real-time continuous monitoring of the patient. So if you have any patient coming in, not doing well on admission in your emergency room, you want to see the ECG as it's happening, okay, and then have blood pressure measure, SpO2 at the same time. In your theater, while you're doing the procedure, you want to have constant monitoring, cardiac monitor. And ECG gives the full picture of the heart, a 12-lead ECG. So you should have both really. Except your clinic is a complete outpatient clinic, then maybe you may just want to do, you may do well with an ECG. But an ECG is you cannot do without an ECG. You should not have a clinic or hospital without an ECG there. When it comes to this thing, you must do a 12-lead ECG to see the heart with all the different angles of that ECG. And once you look at that, it can help you. So I will not say you should buy one or the other. I will say buy both. If you're in hospital, make sure you have a cardiac monitor so that your patients that are critical or in between, you can have it. Most patients don't just die. They are, especially cardiac patients, their cardiac monitors will have been showing some abnormalities on and off before they finally die. So if you don't have one, you will not have one. Then an ECG, you cannot diagnose MI. If patient having a heart attack, the palpitation is important. So an ECG is invaluable. So when it comes to chest pain, they must have an ECG within 10 minutes. So if there's a heart attack, you can start treatment or refer appropriately to the right place. So yes, both of them are extremely very, very important. Okay, I cannot see any other questions, so I think we will call it a day. Thank you very much again for joining us here at Cardio Care. We are very happy. We're very happy to be a leader We're very happy to be a leader and an industry leader in cardiovascular medicine in Nigeria, pioneering teaching, pioneering webinars, seminars, symposia, interventional cardiology, and now we are going on to full-fledged everyday cardiac surgery like we have done for interventional cardiology. I hope that you partner with us, you get your patients the best, and join the WhatsApp group. If you are not in the WhatsApp, just send an email or a message, and we'll be able to get you there so that you can assist and walk along. We'll share the slides with you from a registered email, so you can get the slides and your CME points as appropriate. Once again, thank you so much, and have a lovely weekend.